So we are starting with infective endocarditis. So this is endocarditis. It's the inflammation of the endocardium. So infective endocarditis, even from the word is infective, meaning that it is being caused by infectious agents. There can be other things that can cause inflammation of the endocardium, but for here we are specifically concerned with infection. So infective endocarditis is infection of the endocardium or the vascular endothelium of the heart, okay, like the heart. It may occur as an acute infection, but more commonly can also run an insidious course. So, in other words, it can appear acutely, like someone is being okay, and then suddenly they develop the symptoms that we are going to talk about, or it's over a long period of time, the symptoms are developing slowly. So that's how infective endocarditis can get to happen. So the one that develops slowly over a long period of time, we call it a subacute bacterial endocarditis. And then we have got the acute one. So infections occur, number one, on the valves which have a congenital acquired defect, and it not affects the left side of the heart. So for the valves, the most affected valve is actually the mitral valve. Okay, that's the one most affected. And then for right-sided endocarditis, it normally happens in the IV drug users. For people that use these drugs IV, what happens is that for them, they they when they're using their drugs, they are injecting themselves. The thing is that these was because of the injection, whatsoever that is going on in their body is first going back, because blood at the end of it all first goes back to the right side of the heart. That is why IV drug users, the most common type of endocarditis is right sided. Endocarditis can also happen on a valve that is normal, but you need a very virulent causative agent. For example, Streptococcus pneumoniae and Staph aureus. So please take that these two are very virulent, Staph aureus and Streptococcus pneumoniae. Also, prosthetic valves, like someone, their valve was failing, and so they ended up being put a new valve, a prosthetic valve. What happens that that valve can also be infected, and that happens, it can be early or late. For example, within 60 days of valve surgery or later on. So the infected prosthetic valves, in this case, have to be replaced. Infective endocarditis can also happen in association with the ventricular septal defects. For example, the atrial septal defect, ventricular septal defect. And really, how the pathology happens is, there is a mass of fibrin, like on the valve. You are more like forming a clot. Okay, there is a mass, like fibrin is being laid, platelets are going there, the infectious organism. So we call that as a vegetation. Like these, more like masses or clots on a valve, we are called vegetation. So you'll be able to see those. The virulent organisms will be able to destroy the valve, and then they'll produce regurgitation and worsening heart failure. So if someone has got heart failure and then you end up destroying the valves, that can get to cause regurgitation. And really, regurgitation is where, because the valve is incompetent, when blood is moving through the valve, blood is ending up going back in the direction which was coming from. That is regurgitation, because of incompetence of the valve. Okay. So how do you get to classify ha- uh, infective endocarditis? With the classification, we have got different ways. Number one in which we can classify them is looking at it if it is acute or subacute. The acute infective endocarditis is going to be caused by Staphylococcus aureus, which is very virulent. So another virulent organism we mentioned is Strep pneumoniae. Now, for Staph aureus, it doesn't matter whether the valve is already having a problem or the valve is okay. It can still attack any valve. So it also occurs in normal valves. And normally, if someone is untreated within 6 weeks, they're going to die. For subacute infective endocarditis, it happens with those organisms that are less virulent, like the Strep viridans and the Enterococcus. Okay, you have got Enterococcus faecalis. So these ones subacute to only happen on the valves that are not okay. It doesn't happen on valves that are fine. You also have the endocarditis that will happen in people that use drugs, IV drug users. And this one, as we said earlier, it normally presents with right-sided endocarditis, meaning that the valve that is affected here is the tricuspid valve. Okay, very important to understand that, the tricuspid. And the common organism that causes infection in someone that takes drugs, IV drug user, is Staphylococcus aureus. The others can be Enterococcus and Strep, and also including fungi like Candida and Pseudomonas, which is gram negative. You can also classify infective endocarditis looking at the organisms that are causing it. For example, you have got organisms that cause native valve endocarditis and then those that affect prosthetic valves. Native valves, these are our valves in the body. And then prosthetic valves, these are the ones that have been just put in the body. So for native valve, the commonest organism that affects a native valve is Streptococcus viridans. Other organisms include the Staph species. So I've got Staph aureus and Staph epidermidis. But when it comes to native valves, the one that affect the Staph guys, the one that affects more the native valves is Staph aureus than Staph epidermidis. You also have Enterococcus and Streptococcus. Now, specifically, Strep bovis, when it causes endocarditis, there is also an increased risk of colonic cancer. So someone is going to have these symptoms or features of endocarditis, and then they have got the symptoms of colon cancer, because the strep bovis is going to cause both of them. Actually, strep bovis is gotten by drinking unpasteurized milk. You go to a cow direct, you start feeding from the cow. So that is what causes the problem. You also have what we call the Hazek group of organisms. So for the Hazek group of organisms, you need to know them. The Hazek is an, a mnemonic to say, or just letters representing the organisms. So the H is Haemophilus. It can come in an MCQ. H is Haemophilus. A is Actinobacillus. The C is Cardiobacterium. The E is Echinella. Please know the spellings also. And then K is Kingella. So that those are the Hasek organisms. These guys can affect native valves. And then for the prosthetic valves, like you have got organisms that affect prosthetic valves just 2 months, 2 months before, like after the time you put a prosthetic valve, just below 2 months. And then there are those that will affect valve after 2 months of putting the valve. So those that affect the prosthetic valve less than 2 months after surgery, you have got staph species, staph epidermidis and staph aureus. But can you see that it is opposite here? Staph epidermidis affects prosthetic valves more than staph aureus within 2 months. For the native valves, this Staph aureus was doing it more than Staph epidermidis. And then you have got after 2 months, strep becomes very important. So you have got Streptococcus viridans, Streptococcus bovis, and then you also have Enterococcus. Okay. So these are the big ones. So what is etiology? What really causes infective endocarditis? It's the same organisms that we are from describing. So you have got the common causes. You have got staph, strep viridans, staphylococcus aureus, and enterococcus. These are the common ones. And then you also have sometimes someone is going to have the infection, but then when you do culture, it is not showing anything. So we call those as the culture negative. Okay, the culture negative. There are some organisms that are specifically going to be giving you a negative culture, but then they are there. It's just that for for them it is a bit hard to pick them on culture. For example, Coxiella bagneti, it causes Q fever. Chlamydia, Bartonella species, which causes stretch fever and cat scratch disease, and Legionella. So these four guys, normally, when they cause infective endocarditis, you do culture, you find culture negative. There are some risk factors that are associated, and these are important as you are clicking. You are trying to look for these, okay, in the history. So if someone has got cyanotic congenital heart diseases like the tetralogy of Fallot, so those guys are a risk factor. Surgical constructed systemic pulmonary shunts, if you have got these pulmonary shunts, previous infective endocarditis is also a risk factor. Having a prosthetic valve is a risk factor. Cardiac transplantation recipient who develop cardiac valvulopathy, problems with the valve. So these ones are also at risk. Someone that has got hypertrophic cardiomyopathy and also atrial septal defects. So they also have got high risk. Someone that has got ischemic heart disease. Ischemic heart disease is also known as acute coronary artery syndrome. This is why you find the myocardial infarction and the unstable angina. So these guys are also at risk. IV drug users, those people that have got poor dental hygiene, someone that has got a central line placement or long-term hemodialysis. So blood is, you are trying to clean their blood every time and it's been long. They can have these infections. And then even someone that has got an indwelling catheter for long, they've been having this catheter, infection can also happen. And then also having recent procedures like GI, GU procedures, surgical wounds, and someone that is diabetic or has HIV, they are also at risk. So it's important for us to know the risk factors so that we can ask them as we are clicking. So the clinical features of someone that has got infective endocarditis, the symptoms are going to come about, number one, because of the systemic features of infection. If someone has got an infection, what are the systemic features? Malaise, fever, night sweats, weight loss, anemia. These are the B symptoms, including anemia. They are also going to have slight splenomegaly, someone that has got infective endocarditis, and also clubbing. Remember, in clubbing, the C actually there represents not really the C, but clubbing itself, the I in clubbing is infective endocarditis. Another thing that causes the clinical features that we see in someone that has got infective endocarditis is the destruction of the valve. And when valves are destroyed because of these organisms, it leads to heart failure and also to a new or a changing mama. This is a characteristic feature. Someone comes with a new mama or a changing mama, and then they're also having B symptoms. The first thing you think of is infective endocarditis. Another thing that results in two clinical symptoms is what is known as a vascular phenomena. So what happens is that when a valve is destroyed, it is prone to forming these clots. And when the clots form, they can end up breaking and then embolize. So the emboli can go to the brain, to the spleen, to the kidney. The emboli can also go to the lungs, causing pulmonary embolism that can cause infarction and also pneumonia. And also, one of the vascular phenomena is with the genuine lesions. These are painless erythematous macules on the palms. So you see red um, macules on the hand, and they are painless, specifically on the palms. And then another thing that happens is that when you are having these bacteria in the body, or or the fungi, or these are organisms that are causing problem to the valves, the immune system can come in to try to fight them. And so you end up forming these antibody antigen complexes or immune complexes. And these immune complexes, what they do is that they can lead to inflammation of the blood, the vessel, the blood vessels. They can lead to petechial hemorrhage in the skin. And then on the nails, they can lead to splinter hemorrhages. And then the immune complexes can also go to the eye, and then they can lead to rot spots, and then they can also cause Osler's nodes, which are tender subcutaneous nodules. Difference between the Osler's node and the general lesion is the Osler's nodes, these are tender in the fingers. And please take note of the signs that we are talking about. The only vascular phenomena is general lesion. The rest of the phenomenon, or the rest of the features, are falling under immune complex deposition. You are also going to have, if these immunocomplexes are deposited in the joints, someone is going to have arthralgia or pain. And then if they are deposited in the kidney, someone is going to have glomerulonephritis, not glomerulonephro, not nephrotic syndrome. This is nephritic syndrome, where you are going to have blood in urine. But the blood is actually microscopic. You can't see it on physical exam. It's microscopic. Okay. So endocarditis should always be excluded in any patient that has got a heart murmur and they have got fever. When it comes to the diagnosis of infective endocarditis, we use what is known as the modified Dukes criteria. It's a very important one that has to be known. Okay, a lot of questions will be coming after you click a case when you are presenting. Modified Dukes criteria. So for the modified Dukes criteria, there are specific things that you look at. You have got the major criteria and the minor criteria. So for the major and minor criteria, if you have got two major criteria, or one major and three minor, or five minor, then that means you can diagnose infective endocarditis. Okay. But besides the major and minor criteria, there should also be evidence of infective endocarditis, either by history or culture of the organism. There should be evidence that someone has got infective endocarditis. Infective endocarditis has got complications, for example, heart failure because of the damage of the valves. They can also have paravalvular abscess, also various solid organ damage because of the emboli that can form. For example, to the lungs, septic pulmonary emboli; to the muscles, intramuscular abscess; genuine lesions, epidural spinal abscess, renal abscess, cerebral emboli. So if the emboli goes to the brain, it can cause cerebrovascular accident or stroke. And then the immunological deposition of these immune complexes can cause Osler's nodes. You have got glomerulonephritis, septic arthritis, the rot spots in the retina, splinter hemorrhages. All these are complications. So the modified Dukes criteria has got major criteria and minor criteria. So you need to know this one. So what are the major criteria? Number one, you need a positive blood culture for infective endocarditis. There are three things that you do to say that, okay, this is a positive blood culture which falls under major criteria. Number one is typical microorganism for infective endocarditis are going to be gotten from culture from at least two separate cultures. What are the typical organisms? Streptococcus viridans, Streptococcus bovis, community acquired staph aureus, and Enterococcus. So Strep viridans, Enterococcus, staph aureus, Strep bovis. These are the typical organisms. So if you do two cultures and both cultures are positive, that is the meaning of positive blood culture. Another thing is persistently positive blood culture, which is defined as number one, the recovery of a microorganism consistent with infective endocarditis from culture drawn more than 12 hours apart. Okay, like you get cultures more than 12 hours apart, and then you have got those organisms that are consistent with infective endocarditis, the blood culture comes out positive. So that means someone has got a positive blood culture. So recovery of organisms, let's say number one, you do a culture, 12 hours later, you do another culture, and then they are both positive for the organisms that are consistent with infective endocarditis. Another thing is, let's say you do three blood cultures and all of them come out positive, and the first blood culture and the last blood culture should be at least 1 hour apart. Okay, let's say for example the first one you do at 10, you do another blood culture, another one at 11, the third one, all of them come out positive. That's also a positive blood culture. Or you do more than three blood cultures and the majority of them come out positive, but the first one and the last one should have been done at least 1 hour apart. That is a positive blood culture. So you see, you're at least doing a lot of cultures. But there's one organism such that if you just find one positive culture for that organism, it means that you have got a positive blood culture, which is a major criteria. The organism is Coxella barnetti. So if you just do one blood culture and then it ends up being positive for Coxella barnetti, it means that that's a major criteria, positive blood culture. Another thing is, besides the Coxella barnetti, is when you see antiphase IgG antibody titer greater than 1 to 800, that is also a positive blood culture. So this is the meaning. So saying just positive blood culture for infective endocarditis is not enough. You need to know, what do we mean if we say positive blood culture? Typical organism for effective endocarditis in at least two cultures, persistently positive cultures for organisms that have been cultured at least 12 hours apart, or all of the three cultures that we have done, or majority of the four cultures or more that have been done, they should be positive and they were done at least the first and the last being 1 hour apart. Or single blood culture for Coxella barnetti or antiphase IgG antibody titer greater than 1 to 800. That's number one criteria. Number two criteria is evidence for endocardial involvement. You need to know, you need to find out that actually the endocardium has been involved. You can do a transthoracic echocardiogram or transthoracic echo or transesophageal echo. Transesophageal echo is better for someone that has got a prosthetic valve. Transesophageal for anyone. So what are you going to see on echo? There should be It should be showing oscillating intracardiac mass, like there is a mass that is moving, okay, inside the heart on echo. That will be like a vegetation. Or on a valve, you should be able to see this mass that is oscillating, or supporting structures in the path of regurgitant jet or implanted material in the absence of an alternative anatomical explanation or abscess. So when you see an abscess on echo, transesophageal or transthoracic, or you see a mass, or you just see something that you can't explain anatomically on echo, on the valve, or on the implanted device, that is evidence of endocardial involvement. And then another major criteria is new partial dehiscence of prosthetic valve. So you've put a prosthetic valve and then this prosthetic valve breaks. New partial break in the prosthetic valve, new partial dehiscence. That's also a major criteria. Number four major criteria is a new valvular regurgitation. So this patient develops a new valve regurgitation. Okay, so these are the four. So if you just have from all these four, if you just have two major criteria, then you can diagnose infective endocarditis. On the minor criteria, you have got predisposing conditions. On the predisposing conditions, you are trying to look at risk factors. Okay, for example, someone has got a prosthetic valve, is an IV drug user, so such. And then number two, any microbial evidence positive blood culture. So they have got a positive blood culture, but that blood culture is not consistent with the major criteria. Then it falls into minor criteria. For example, not all the blood cultures are positive, maybe only one. And then positive echocardiogram. Also echo that is not consistent with the major criteria or fall under minor criteria. And then you have got fever. Someone that has got a temperature greater than 38 degrees. You also have immunological phenomena where I've got ulcers, nodes, glomerulonephritis, Rots spots, arthralgia, rheumatoid factor, and then vascular phenomena. So for the vascular phenomena, the only sign that you look for there is genuine lesions. The others, you have got septic emboli, pulmonary emboli, mycotic aneurysm, intracranial hemorrhage. So these are the minor criteria. There's actually a mnemonic we use to remember this. Okay, so it's B 5 p.m. B 5 p.m. The B and the E, 5 is not the number 5 but FIVE and then PM. So the B is and the E, those are representing the major criteria. Blood culture should be positive, and then E is the echo. Echo should meet these criteria which are here. And then for the 5 p.m. The other one that they use is B timer. Okay, so for the 5, F is fever, greater temperature greater than 38. I is immunological phenomena where I've got oslasmos, glomerulonephritis, toe spots, arthralgia, rheumatoid factor. And then the V is vascular phenomena where I've got the genuine lesions, pulmonary emboli, and then E at the end is endocardial involvement. But this not endocardial involvement, but echocardiogram. The second is the echocardiogram, which has a minor criteria, not major criteria. And then PMP is for predisposing factors like IV drug use, prosthetic valve, recent dental procedure. And then the M is the microbiological evidence that doesn't meet major criteria. So you can also use that mnemonic to remember the major and minor. So for that mnemonic is just that the new valvular regurgitation is not part of that mnemonic, and then the new partial dehiscence of prosthetic valve is not also part of the mnemonic. So if you want to see the Rots spots, which is part of the immunological phenomenon, you are supposed to do a fundoscopy. Therefore, if you are clicking a case of someone that has got infective endocarditis, it's important for you to mention that I would have loved to do an endoscopy. They just want you to mention that. It means that you know what you're talking about because of the Rot spots. So the investigations that you do is basically, so you want to find out if, to confirm your diagnosis from the history. You are going to collect blood cultures. You are supposed to take blood cultures before you can start antibiotics. So collect the 3 sets. So you can do a transthoracic echocardiogram or the transesophageal to look for these abscesses and the masses on the valves. You can also do serological tests, okay, which can be helpful in identifying the organism, for example, Coxella, like the unusual organisms, Coxella barnetti, Bantonella, Legionella. You can also do a chest X-ray. It will show heart failure features or evidence of a septic emboli, okay, for someone that has got right-sided endocarditis. ECG will show myocardial infarction, and specifically for myocardial infarction, what you look at is the ST segment. There's elevation of the ST segment. So we have got what we call STEMI and non-STEMI. So for the STEMI ST elevation myocardial infarction, the ST segment is elevated. There can also be a conduction defect on ECG. So you'll see problem in conduction. You can also do a full blood count. Remember we said that another complication is anemia. So show full blood count to show normocytic, normochromic anemia. And then there is also a raised erythrocyte sedimentation rate. And there is leukocytosis. There is an increase in the number of white blood cells. Urine dipstick is going to show hematuria. Now, this hematuria, don't pick it up macroscopically, like looking at it macroscopically. It's microscopically. The serum antibodies are going to be increased, while the complement levels are going to be decreased because of the immune complexes. And how you manage someone that has got infective endocarditis is you give them bactericidal antibiotics for 2 weeks, and then followed. So this for 2 weeks you are going to be giving them IV. And then for the next 2 to 4 weeks, you'll now be giving them orally as you wait for the results of culture, because culture takes long, 1 month to 2 months. So you can be giving them IV benzopenicillin, you just give them penicillin and gentamicin. Now, for staphylococcus, it's normally resistant to these drugs. And the only drug that you can use is vancomycin for staphylococcus. So that is why it is best you are using gentamicin and you are using vancomycin. Because at this point, you don't already know the organism that is causing the problem. At least if you give vancomycin, it can treat any organism. But if you give the penicillin, it can't treat, it can't treat staph in case the staph is the cause of the problem. Okay. So subsequent treatment is going to depend on the blood culture. So depending on the culture that you are going to have, it will determine what type of treatment you are going to give. You can also do surgery to replace the valve when there is severe heart failure, early infection of prosthetic material, worsening renal failure, or extensive damage to the valve. Okay, so those are some of the things that you can look at. So when you are clicking on history, what you can pick up is someone has got a fever, but a mama, you really don't pick that from history. That is from exam. Someone is having difficulties in breathing because if this, like if someone has got a problem and then the valves are failing, we said that it can lead to heart failure. And for heart failure specifically, the left sided heart failure, it can lead to these symptoms of involvement of the lungs, like pulmonary edema, which causes difficulties in breathing. There can also be chest pains, weight loss, malaise, night sweats, just the B symptoms. And then the complications, for example, they can tell you about nodules, rash, but the nodules will pick them on physical exam. They'll tell you about the past medical history. Probably they are taking medications for the treatment of the condition, the structural heart disease. Okay, probably they know about any structural heart disease that you have tetralogy of autoceptor defect. That is if they know, if they were told. And then recent procedures, like you ask them, have you done a dental surgery recently, GI surgery, GU surgery? Do you use drugs? The IDU drug users, okay, like the IV drug users, IDU. And then for systemic, if someone has got systemic lupus erythematosus, specifically the type of endocarditis they have is known as the Liedman-Sachs endocarditis. Please take note of that one. It's an exam question. So for systemic lupus, you want to ask them about things like if they have got a malar rash, but a malar rash you are going to see. Okay, you are going to see it. And then if they have got some oral ulcers for systemic lupus, you just want to ask that so that the doctor will know that you know what you are doing when you are presenting this case. Okay, I was asking about the oral ulcers just to find out if they've got systemic lupus, which is one cause of endocarditis. It's a differential. And if they've got a cancer, on physical exam, the signs you are looking at is the splinter hemorrhage, clubbing, ulcers, no genuine lesion, also petechial rashes, and also you have got rot spots. That one is when you do uh, when you look at the eye using the ophthalmometer. You also hear a murmur as you get to auscultate, and then when you palpate, there's going to be splenomegaly. Okay. So it's important for you to know where you find these. Genuine lesions are going to be found on the palms or the soles. It's important for you to know that. Osler's nodes, which are painful, they are going to be found on the fingers, the toes, and the feet. Please take note where you find these guys. And then you also have petech. Petechial rashes are going to be found in the conjunctiva, the oral mucosa, and the legs. So take note of that. So that is it. So I've got one question here. A 42-year-old man presents to Clinic 5 with fever, a murmur, dyspnea, chest pain, anorexia, weight loss, malaise, night sweats. What other things will you ask in the history? What is your diagnosis? List 4 complications of your diagnosis. How can you diagnose this condition? What physical findings will you look for on examination? What investigations will you order to confirm the diagnosis? How can you manage this condition? So some things you can ask about in history is if they have got any structural heart disease, if they've had any recent dental procedure, are they IV drug users? Okay, if they've got non-bacterial thrombotic endocarditis, so you want to ask about features of systemic lupus erythematosus, and that's known as Liebman-Sachs endocarditis. So, for example, if they've got oral ulcers, a malar rash, and other features. If they have got malignancy, especially adenocarcinomas, they've got cancers. Okay. Also want to ask about the drugs that they use. So our diagnosis here is effective endocarditis. List 4 complications. We've talked about the complications like the genuine lesions, pulmonary embolism, stroke, the Osler's nodes. What physical findings do you look for? Those same things. Petechial rash, where do you look for it? Petech in the conjunctiva. You're also trying to look at the oral mucosa and the legs, genuine lesions, Osler's nodes, road spots, all those features. What investigations will you order to confirm the diagnosis, and how can you manage this condition? So how can you diagnose this condition? Use the modified Dukes criteria. Investigations you can order. You have got labs, microbiology, imaging. Imaging, you look at the chest X-ray. So when you are writing again, you don't just put imaging there. You also need to mention what are you trying to look for as you do that investigation. For the chest X-ray, features of heart failure or septic emboli in right-sided endocarditis. Echo identifies vegetations or these masses on the valves. You can also do the CT of the chest, the abdomen, and the ECG to look. For the ECG, you are trying to look for myocardial infarction or heart block. Microbiology, you do blood cultures before antibiotics are started. You can do a sputum gram stain just to eliminate other causes of let's say for example this person has got dyspnea, right, and they've got these respiratory features. Maybe they have got TB. Okay, uh, acid fast bacilli, you want to look at that. That's why you're doing this sputum gram stain, because you said one complication for infective endocarditis is pneumonia, so which can present similar with the other respiratory conditions. You also want to look at a full blood count, where you're going to be able to see. So again, the same microbiology. When you do this blood count, you get blood. You see normocytic normochromic anemia on the peripheral blood smear. You look at the cells. And then you also see a raised erythrocyte sedimentation rate and reticulocytosis. On the labs, you also have supportive labs. You have a complete blood count. You just look at the blood, you compare the number of cells, and we are saying there is raised white blood cells, decreased red blood cells. You look at the liver enzymes also. Liver enzymes like AST, ALT, liver function tests like bilirubin, you also look at those. And then for the treatment, we said you give benzyl penicillin or gentamicin with gentamicin. But penicillins are a bit not helpful if someone has got staph infection because resistant, so you want to give vancomycin in that case. So that is it for this discussion. Thank you so much. Hope you got something.